Okay. Well, good afternoon. This is PNR 203.2, and this is a exam review. I'm going to go ahead and share my screen and bring up the PowerPoints that I sent out for the exam review. And we have to go back because the chapters involved are chapters 2, 3, 4, and 5. Okay, so chapter 2 starts with you have your pelvis, your external structures. Now, heads up, okay? And what does my heads up mean? It means that you probably see this again. The gynecoid pelvis is the most favorable for childbirth, okay? And just to let you know that the android pelvis is very similar to the male pelvis. And then the anthropoid is long and oval shaped, and the planetoid is a flattened shape. Now that one is very unfavorable for childbirth. And over on the screen here, you can see the difference in the different pelvises, okay? So we want to have a nice round pelvis for enough for a head to what? To get through. Okay, and then you have your other structures. You have your vulva, which has your clitoris, urethra, vagina, and the mons pubis. Now, another term, perineum, I want you to know. And that is the area. We call that, another name for that is called a fourche. That's the obstetrical perineum. And then you have your labia, the majora, and the minora. Okay. All right. So we're going to go right on. And here we go into the human reproductive anatomy and physiology. Okay. So what I want you to know is about the fallopian tubes. So what happens in the fallopian tubes here? That's where the eggs travel. Yes, yes. So what occurs? So that ovum is released, and then it comes right here, and it's called the ampulla of the fallopian tube. Write this down. Fertilization occurs. That's where the sperms, they traveled up to the fallopian tube and met that egg over here. And then that's called the ampulla, and that's where fertilization. Then what happens? It just travels down into the uterus and plants itself on the what? Posterior wall in the uterus. Okay, so there could be a question about the fallopian tube and where does fertilization occur. So just giving you a heads up on that. Okay, and then over here we have our uterus. And as you can see where the uterus lies right above the bladder. So whenever the bladder's inflamed, like, go ahead and mute yourselves. When the bladder is inflamed, it causes the uterus to contract. Okay, so that's why when we studied in like the complications of pregnancy in chapter 5, we study about UTIs, and we don't want that to cause preterm labor. Okay, so you can see the uterus there, and the uterus looks like an upside down pear. You know, here you go to the store and look at the pears. It looks like just take a pear and put it upside down. Sure enough, because there's the cervix, and then you got your fallopian tubes, and your bladder and the rectum. So that's basically your reproductive anatomy and physiology. And we're going right into functions of amniotic fluid. Now, this was, I think, believe it or not, a quiz. So you probably see this again. So functions of amniotic fluid. Well, with this fluid, it maintains an even temperature. Okay, and it also prevents the amniotic sac from sticking to the fetal skin. Yeah, see this fetus in here, how he's floating? Well, he needs that amniotic fluid in order that he doesn't stick to the sac. All right, and then it allows for even growth of the fetus. When we say symmetrical, we mean one side is equal to the other side. And then it allows for buoyancy and fetal movement. So the baby can move around and stretch. And without that amniotic fluid in there, you wouldn't be able to do that. And then it acts like a cushion to protect the fetus and the umbilical cord from injury. Like if mom takes a fall or something, that sac is protecting that little fetus in there. Okay. And of course, the umbilical cord, which is your baby's lifeline right there. And remember, in the umbilical cord, you remember the mnemonic AVA? Okay, that means AVA. That's 2 arteries and 1 vein. All right. So that's the amniotic fluid. So, and how many weeks would you feel that the mother feel fetal movement typically? How many weeks should she be?
18 to 20.
Yes, 18 to 20. Now, since you're with me, I'm gonna give you a little hint. You'll see that again. Okay. All righty, you got it. And remember, the amniotic fluid is so important to the baby, okay? And you know, amniotic fluid is made out of urine from the baby. Okay, so again, allows for fetal movement, and it also maintains body temperature of the fetus, and it surrounds and protects and acts as a cushion for the fetus. Okay, do y'all have that? You got
Yes.
it? Okay, good, because you will see that again. Okay,
Yeah.
that's a hint. Okay, moving right along, we got the placenta. And here's your nice picture of the placenta in a placenta basin right after delivery. And you see the umbilical cord right there. Okay, we talked about AVA already, and fetal circulation. Okay, remember it's opposite from what we have. So let me go into hormones. All right, hormone helper. The placenta takes over to make the hormones. And here it is in a nutshell. And so here's progesterone. What is progesterone? It protects the pregnancy by maintaining the lining for implantation. Very important. I would definitely know that. And the next P, it prevents contractions to prevent pregnancy loss. So what I always say, you need progesterone to maintain the pregnancy, and that's where it comes in. And then prepares breast glands to make the milk. So progesterone starts with a P, and you got 3 P's here. Y'all see that? And so you got protects the pregnancy by maintaining the lining for implantation. That lining in the uterus, that's what they need. It needs like good rich soil. And then you prevent contractions to prevent the loss of pregnancy. And that's where that comes in, maintains pregnancy. Everybody got the 3 P's of progesterone down pat? Okay, we're going to move into estrogen. Now, estrogen, you see in this mnemonic here, we have all the E's line right up. So estrogen enlarges the uterus, so it grows. I always thought of estrogen as like a little stimulant, okay? So then you have estrogen. It gives you extra blood flow to the uterus. Estrogen enhances the breast ducts for milk production. Estrogen, extra skin pigmentation. You know that we talked about the linea nigra? Well, that's who's the culprit. That's what causes the linea nigra is estrogen. And then you have estrogen, extra blood flow to the mouth and nose, and extra saliva. So that's kind of neat how that was put together with all the E's. So again, estrogen enlarges your uterus to grow. Estrogen, extra blood flow to the uterus. Estrogen enhances breast ducts for milk production. Estrogen, extra skin pigmentation. And then also estrogen, extra blood flow to the mouth, nose, and extra saliva. And a lot of times you can see test questions about estrogen and what it does. And usually they put in like a test question around the mouth and the nose and like kind of nosebleeds. And you'll see that. Okay, then we go to the next hormone. And what's that? Human chorionic gonadotropin. Now this hormone, as we abbreviated HCG, One, it helps notify the corpus luteum that conception has occurred. It goes, hey, we got a conception going on here. Okay. And then it causes positive urine and blood pregnancy tests. That's where that first hormone comes up in those pregnancy tests is HCG. And it gives early pregnancy symptoms like nausea and vomiting. Okay. And that's what those all are into play with nausea and vomiting. And then the last hormone is the human placenta glycogen. And we abbreviate HPL. And H stands for helps bring glucose to the fetus. Remember, glycogen is sugar, so it comes from the placenta. And then P promotes fetal growth and nourishment. Yeah, baby's got to grow, he's got to get it somewhere. And then lowers insulin resistance to moms. And remember, we talked about that in chapter 5. So HPL plays a role in actually contributes to the risk for gestational diabetes. And that was, again, chapter 5. So here's our little fetus over here. Here's the placenta, and here's the umbilical cord, okay? And he needs these to, what? To grow. All right. So, all right. So does everybody have the understanding of the hormone helpers? And the placenta takes over to make the hormones. Everybody understands this slide pretty good?
Yes.
Okay, good. Now I'm going to move on. It's, this is a review, so it moves pretty quick. Terminology. Okay, so there's going to be a question on your GTPAL. Okay, so we're going to go over what gravida means. So gravida is a woman who is pregnant. Okay. Okay. Number of times she's pregnant. And no gravida is a woman who's never been pregnant and is not currently pregnant. I'm just going to stop right here for just a second. And I'm just making sure that we are recording. Yes, we are. Okay. All right. Sometimes you just have those little doubts in your head. Okay, so again, gravida is a woman who is pregnant. And the number of times she's pregnant. So like you have someone's having a 4th baby, her gravida would be gravida 4. Okay. Now a no gravida is a woman who's never been pregnant and is not currently pregnant. We don't really use this term too often, like we said, but you never know. One of those HESI tests, they might throw that in there. So you always want to know about it. And then the prima gravida is a woman who's pregnant for the first time. Okay, it's her very first. See, prima means first. So this is a first time mom. Now your multigravida is a woman who's had 2 or more pregnancies, multigravida. Now, parity is the number of pregnancies in which the fetus or fetuses have reached how many weeks? 20 weeks of gestation. Now, 20 weeks is viability. So again, the number of pregnancies in which the fetus or fetuses have reached 20 weeks. Remember something, it is not the number of fetuses like twins. Now, it's still with twins, is considered to be still one pregnancy, okay? But where you pick up on it is under living. When you do the L portion of it, that's where you would put, she's a gravida. Say she has gravida and she had twins, you put it under the L. That's where you give the credit to. All right. Now, a prima para is a woman who's completed 1 pregnancy with a fetus that's reached 20 weeks gestation or more. And then again, a multi. I think we just went over this, but it's a multi-para, a woman who has completed 2 or more pregnancies to viability, 20 weeks or greater. And then I guess lightning has been put in here real quick as a terminology, and that's where the baby has dropped into the pelvis, and mommies feel that, and it's really nice because that's when they go, "Oh, my baby's just dropped," and that's usually in the 3rd trimester as it gets close. So if I was to ask you a question, The nurse is obtaining a client's obstetrical history who is pregnant for the first time. Which term would be used to describe the client's gravida and para? So what is she? What's her gravida and para?
Is she gonna be a
Prima
gravida?
She's a what? Gravida 1, right?
Prima gravida.
And she's okay. So she's if you're doing a gravida and parity.
Oh,
Yeah. So she's pregnant for the first time.
Right.
So she's gravida 1, right?
mhm.
Woman who's pregnant. Okay. And then her para, it would be the number of children, right? But she
Mhm.
hasn't had her baby yet, right? So she's gravida 1, para 0.
0.
Yeah. You see how that works?
Yeah.
Yes.
Okay. Now, let me give you another warning. Is when you're asked to, hold on, let's stop share. When you're asked to do a GTPAL, okay, always remember the present pregnancy. Okay, so I see a lot of students, they're figuring up, you know, the gravida para term, you know, the GTPAL, gravida term, premature abortion, living, but they forgot the present pregnancy. So always remember that. Okay, everybody got it?
Okay.
Oh,
Yeah.
yeah. You'd be surprised how many people forget that. And I'm going, oh no, you got it all. You got her TPAL, but you forgot how many times you've been pregnant. And the reason why you're doing this GTPAL or gravida para is you're doing an obstetrical history on her when she comes into your clinic. Okay, so everybody got down gravida and para. Very good. All right. We're gonna move right on then. Oh, here's it. I guess this is a pretty important slide, everybody. So give a heads up to it. I know you will see it on Tuesday. All right. So again, gravida, term, abortion, living, and then we don't use this too much, but you might see multiple sometimes. Okay. So we all keep it real simple. Gravida is the number of times a woman's been pregnant. So if she's coming in for the first time, she would be a gravida 1. Now, term is the number of births after 37 weeks, right? 37 to 40 is term. So number of births after 37 weeks. Because if she's preterm, that would be the number of births between 20 and 37 weeks. Okay, remember 20 weeks is your age of viability. So you would have that pretermer in there. Okay. And then abortion be any pregnancy loss before 20 weeks or gestational weighing less than 500 grams. So abortion, any pregnancy loss before 20 weeks. Okay. And miscarriages are put into that category also in abortion. Now, living for L is the number of children living. So here, what I was trying to get at before was twins or more count individually here. So this is where you give her credit, okay, to how many living children she has. And then the M will be number of multiple gestation, you know. Sometimes we use that and sometimes we don't. Okay, so this is a pretty important slide because you probably have a question on that. Okay. All right, so if you're good on the gravida and para, I'm going to move right into how do we calculate it, estimate day of delivery. So here's your Nagel's rule. I can guarantee that will be on the test too. You'll see that, okay? So it's very easy to do. All you have to do is take the last menstrual period and you back up 3 months and you add 7 days to that first day of the last menstrual period. Now, I did emphasize the first day, okay, because that's what you do. And they could put a question on like her first day was say May 4th. And then her last day of her last menstrual period was like May 12th. And you know that you're going to calculate this going back, adding 7 days to that first day. Don't add it to the second day. So are you pretty clear on that?
Yes.
Okay, good. Okay. All right. I want to make sure because I had students in the past that they had this scenario and they got lost in the scenario. And what happened is that they did the wrong addition to the wrong day, and they got it wrong. So I'm very clear as to it is to the first day of the last menstrual period. Okay, so I think you pretty well got that down packed. I was trying to see if I can have a little bit of, let's see if I have here. Yes, how about this one? Okay, you ready? Okay, because I'm gonna let you guys answer it. Your pregnant client's first day of her last menstrual period was June 12th. Using Nagel's rule, calculate the client's estimated date of birth. Okay, so what is it?
I got March 19th.
Yes, and that is correct. Okay, so everybody has March 19th. Okay, all right. And I tell you what, we do have, this is an obstetrical wheel right here, and we do carry those in our pockets. And you can calculate on the wheel too by going back with the first day of the last menstrual period, and then you have your EDC over here. But this is really simple to do, and it's much quicker, and you don't have to have a wheel. Okay, so we're going to move right along with our signs of pregnancy. All right, now this one here is presumptive. And remember I said on my side I had you things that the person feels. Remember we went over this pretty good. And then the probable is what? The examiner, right? And then the positive here, that's pretty obvious. We got fetal heart tones. So this is how you would look at it and how you study it. So this one says presumptive subject. Patient tells me, makes me presume she's pregnant. Okay. And then, you can tell by the you as this is what you would feel. Okay. The patient would feel nausea, urinary frequency, fatigue, breast tenderness, quickening, amenorrhea, right? Now that's one thing that she would feel, correct? That she would say, presume to be pregnant. Okay. But, there's things that can cause, other things that can cause amenorrhea. Quickening could be that she has a lot of gas. Breast tenderness, she could be drinking too much caffeine and eating a lot of chocolate, which gives you breast tenderness. These are things that can be caused by other problems. Okay. Now, under probable, this is what the examiner, so probable objective signs, objective, I can observe as a provider, makes it more likely, probable she's pregnant. Okay, so again, I'm the provider, I'm looking at my patient, so what do I have? Objective signs, and that would be your Hager signs, your Chadwick sign, and your Cordell sign. These are all pretty well that the provider can see. Okay. All right. And I would definitely know the Chadwick sign into my memory. And then positive. All right. Now these are pretty positive. You hear fetal heart tones. Bum, 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 bum. You have an ultrasound, and there's the fetus laying really nicely inside that uterus. And then if the provider can feel fetal movement by palpating the uterus, you're pregnant. So again, positive, the provider sees and hears and feels the baby or fetus. Okay. Any questions on these? So know those. So if I was to ask you guys, what is a positive sign of pregnancy? What, and you had choices such as breast tenderness. That's not positive, correct?
Right.
Correct.
Morning sickness is not positive.
Right.
Okay. A positive pregnancy test is not positive.
No.
It's
not.
It's probable.
Okay. It's close to it. See here, positive urine blood pregnancy test.
Yeah.
Okay. But if the other choice was fetal heart sounds were heard, would that
would
be
be positive.
that'd be positive? So
Yeah.
that's how, so that's an example of how the question is asked, okay? How the question is asked. So that's why you got to know these. And I would just say, know these like presumptive, that's subjective. My patient tells me. Okay. But am I really sure? Not really. Probable. This is as the provider, you're looking at things, but are you sure? Okay. Is likely she is. And then the positive things is that as a provider, you can hear the heart tones, you can do an ultrasound, you can see, and this is feeling. Does that kind of help you a little bit by going over this like that?
Yeah.
Okay, because it definitely is a question about this. All right, we're going to move right along with the common discomforts of pregnancy. Okay, so common discomforts of pregnancy. Well, she's got a backache and the feet are swelling, mild shortness of breath, breast tenderness, heartburn, nausea, vomiting, fatigue, urinary frequency, and constipation. Okay, well, I think I gave you on that sheet, I did give out a little bit about all this. So you want to probably just kind of look over that a little bit too. But yeah, backache, she's got that big old uterus in the front and it kind of puts her back out. And it's kind of what we have a little bit of lordiosis going on there. The feet swelling, okay. And well, we have increased fluid volume in the body. So if she's on her feet too much, then the feet are in a more dependent position, you get more swelling. The mild shortness of breath, the uterus grows up into the abdominal cavity and kind of pushes against the diaphragm, and it makes it harder for her to breathe. Breast tenderness, yeah, those hormones we talked about, and you got the production of prolactin, and the breasts now get tender. The areola gets very dark due to hormonal changes. You got heartburn because the uterus now gets is pushing up against the stomach. You have nausea, vomiting, and then urinary frequency and fatigue and constipation. So now headaches can occur, but be careful. We want to be careful with headaches because if they're repeated or they're severe headaches, they can be a warning for gestational hypertension or preeclampsia. So that's where you're taking her blood pressure and you want to see if it's escalating, it's increasing. You use that 30-15 rule and yeah, be careful, we got to make sure. And then we're going to test her urine and see if she's got any protein in the urine. That lets us know that we could be getting into more of a preeclampsia condition as we discuss in chapter 5. Okay, now all these little discomforts, they can get in the way of her normal daily activity. So what are we going to do to ease her discomfort? Well, we always want to do non-pharmacological means if we can. So we're just trying to pick comfort measures that don't involve medication. And never pick an answer to limit fluids. Okay, on the test, you don't want to ever limit fluids. We want to give her, well, how many glasses of water should she have a day? About 8 to 10, right? And never pick a diet, never pick to diet to lose weight in pregnancy. No, we don't lose weight in pregnancy. And when you have an obese patient that can't, they have a limited amount to gain, we want to make sure that they're eating, but we're eating what? We're not eating empty calories. We're eating, protein with a good balance of your protein, your carbohydrates. And then never put a pregnant woman on her back. What's that called when we put a pregnant woman on her back?
Supine
Supine hypotension.
Yes. Yes. I believe I can guarantee that you'll probably see that again. So you don't it was on quiz number 2, I believe. So you don't want to put a pregnant woman on her back because of the supine hypertension syndrome. And what happens is the poor baby, he feels it. He gets less blood supply. And so that's why we always like to labor and put moms, if they're sleeping, preferably on the left side, okay? Because you get better perfusion. And we want to give the baby all the good oxygen that mom has to give. Okay, so what's our good advice for her? Okay, so she's going to have small, frequent meals, drink water, and decaffeinated fluids, and increase her folic acid, because folic acid is vital for what? Is vital to prevent
Neural tube defects.
Yes, exactly. Good. And then we got our iron. I would definitely know what foods you're going to tell her to eat to give her the best iron. I know Hessie likes those kind of questions too.
like leafy vegetables.
Yeah, green leafy vegetables. Oh yeah. All right. So make sure that you go over that, and that's right in one of the chapters we did, and it's right on a slide. I gave you all that. And then we have exercise, DHA, exercise like walking or swimming. I always tell my patients walking is really simple. You don't need a pool. We're swimming, you need a pool, right? But walking, you get out, put some sneakers on, and at least after eating, right? It's better for digestion and also better to maintain blood sugar levels. And always limit greasy and spicy foods. Normally, they have a hard time with spicy foods because they start to get what? Heartburn, and then they get nausea and vomiting because of all that. So we want to tell them to limit. Please don't eat too many greasy foods, all right? It's just the body has a hard time breaking that down. Okay, so prenatal care. Okay, so we start care as soon as pregnancy is identified, usually about 6 to 8 weeks, and some places up to 10 weeks, because at 10 weeks usually that's a time when the uterus now comes out of the pelvis and more just slightly up, just above the symphysis pubis, so that you can see the fetus and everything, and you can maybe pick up Doppler fetal heart tones. The visits are monthly, okay, up to 28 weeks. And then every 2 weeks from 28 to 36 weeks. And then that last month, every week, greater than 36 weeks to whenever she delivers, okay? That could be to term, it could be 40 weeks, then we get to post-term, you get 41, you get to real late term, you get to 42 weeks. Okay, but she has to come every week, because what we're gonna do, every visit, we're always going to so here you go. Every visit, you're always going to weigh your patient. You're going to do her vital signs. We're going to listen to fetal heart tones, and we're going to do fundal height. Now, it's very significant because weight, if she's starting to swell and retain fluid, you're going to see her weight go up very fast. That's a good way. The vital signs, we're looking for that 30-15 rule with the blood pressure. Okay, so we want to make sure if she's starting to go up on her blood pressure, we want to make sure that we're on top of things. Okay, and the fetal heart tones every visit, and you use a Doppler to pick up fetal heart tones. And the fundal height. The fundal height is really simple. You put the tape measure on the symphysis pubis and come straight up the linea negra, and you come to the top of her uterus, which is the fundus, and you measure. Remember, if she's 28 weeks gestation, she should measure 28 centimeters, correct? Okay, so that's a real simple tool we can use in order to see if baby's growing too fast. So if she's supposed to be, say, 28 weeks gestation and she's measuring 32, that's pretty significant. We have a large baby in there, do we not? Okay, and so we could follow up by doing ultrasound to see what's going on. And the same thing is if we have a mom who's supposed to be 28 weeks gestation and she's measuring 25 weeks. We got a baby that's not growing. Okay, so see, that's a real simple way to know if this fetus is growing the way it should be. And every visit, we do a urine sample. The urine, we're going to look for glucose. We're going to look for protein, WBCs, nitrates. I know the big sticks have bilirubin and all that, but that's some basic. And because we want to know the protein, because if her blood pressure is going up and she's spilling protein, we can pick up on what? Preeclampsia. If she's about 23 weeks and she's spilling glucose in her urine, then we need to follow up with more of a test, get her in for the screening, and then get her in for a glucose tolerance test based on the screening results. So you see that urine sample is so important. Honestly, it is. Okay. And because remember, chapter 5 went over the complications in pregnancy. And so, and you can see where all this testing comes into play. Now, your warning signs of complications is education based on how many weeks she is. So say ultrasound. We do an ultrasound, say at 10 weeks, in the very beginning of pregnancy, right? To pick up, make sure, one, that there is a heartbeat in that on that ultrasound, and it's positive, and it's a possible sign of pregnancy, correct? Okay. Then if she's a low-risk pregnancy, the next ultrasound is done about 20 weeks gestation, because we're doing a full anatomy scan, okay? And we can see the length of the femur, we see the heartbeat, we can actually see the 4 chambers when you look at these ultrasounds. And they're really, some of them are really, really neat, you know, like they're in 4D, and you can see the face of the baby and everything. They're really neat today. So that's done about 20 weeks, because when you can see the full anatomy really great at 20 weeks. And then if they want to know what they have, they want a boy, say if they want to know if it's a boy or girl, that's a really good time, because that's when you can see the genitalia. Okay. And then some important test. Remember, we talked about gestational diabetes tests. You have another test called group beta strep testing. And that's done to determine if she's positive for group beta strep, because we don't want a baby born through a vagina that has group beta strep, because remember, group beta strep can cause a baby to be very, very sick. And also it causes babies to die if they get that sick, because they breathe that in, and then they can get respiratory distress syndrome or hyaline membrane disease. So we want to know if they're group beta strep positive, because all we have to do is give antibiotic in labor. Okay. And then remember our vaccines. The flu vaccine can be given, and the Tdap, that's given after 27 weeks. You do not give a live virus to a pregnant woman, such as rubella. So rubella is never given to a pregnant woman. If she's not immune, you don't give it during the pregnancy. You wait till after the pregnancy, and you can give it then. And she can breastfeed with that, but you can never give a live virus to a pregnant woman. Okay. And here we are, immunizations in pregnancy. All right, so again, I'm just repeating myself, but I guess it's good to repeat. Live virus vaccines, and there's your MMR, that's your measles, mumps, and rubella, and they're contraindicated during pregnancy. Okay, then thimerosal should not be given during pregnancy because it has mercury. And so you never want to give someone mercury poisoning. And then avoid pregnancy for at least 1 month after receiving, so that, you know, the rubella vaccine, she has to wait a month. So if she's not pregnant and she's coming in for a preconception visit, which is lovely, and you find out she's not immune, okay, then you can give the shot, but she has to wait 1 month after receiving that MMR, okay? So the thing is, you can never give a rubella during pregnancy. And then you just select immunizations that are allowable during pregnancy, and we went over that. You can give the flu, the injectable form, and the Tdap. That's it. Okay, so let's go on. So if I was to ask you a question about which of the following are part of a routine assessment made at each prenatal visit. Okay, so you know, that could be like an all that apply. So would it be weight? Would it be group beta strep testing? Would it be a urine dipstick, vital signs, or ultrasound? Now, what was the question? The question was routine assessment at each prenatal visit. So what would you do at each prenatal visit?
Urine,
Okay, urine is correct.
vital signs.
Vital signs.
Yes.
The blood glucose. Would you do that?
No, this is the question asking you assessments made at each prenatal visit.
Oh,
The fundal height and fetal heart rate.
Yeah.
What I'm trying to see here.
what about nutrition?
Well, yeah, we can talk about that. Yeah.
Well, and then you ask about discomforts and problems since the last visit.
And what about let's see. What about this little word here? What's this one?
Oh, well, weight I included with vital signs.
Oh, okay. I didn't hear the weight. Okay. So yeah, you want to make sure that, you know, your choices. So that's good. Okay, I didn't hear that. Okay. All right. Then you got it. All right. So here it is. Routine assessments at each prenatal visit. Okay. We always go over risk factors, right? Then vital signs and weight. Good. Yeah, I thank you. Your analysis, your protein, and you said that, glucose and ketones. This blood glucose screening is not, you know, I mean, it's not done at each prenatal visit unless she is like a type 1 diabetic, but this is not, shouldn't be at each one, okay? And then fundal height, yes, fetal growth. And then not only fetal growth, I meant to tell you also about amniotic fluid volume. Because if she's measuring, say, too big, we would do an ultrasound to see the fetal growth, but also we're going to do an amniotic fluid index level. Okay, so that's what that means. And then we do a Leopold maneuver, because what we're doing, we're assessing if the head is down, or what kind of presentation the fetus is in and position. And when
would that be getting done at every visit though?
Yeah, you know what they do? I'll tell you what we do. We do it so quickly that we're touching the belly. Okay. And then we also do that, I'm gonna let you know, to figure out where we're gonna pick up fetal heart tones. Okay, before we put the Doppler. So it's kind of like we do that so quickly.
Right.
To determine, yeah. But as you get longer, toward the end, they'll do more of the lever pulse just to make sure that the head is down and she's not in a breech position. And then fetal heart rate, nutrition intake. Well, it goes back up to weight. If they're gaining a lot of weight, then we got to make sure, what are we eating, right? So we want to know. And then any discomfort or problems since your last visit. Okay. All right, so that's what's done at every prenatal visit. So you might see that again. Everybody got that? All right, I hope you got it. Say yes, yes. Okay. All right.
Yes.
Okay, thank you. All right, so some normal physiological changes in pregnancy. So remember, pregnancy causes many changes. I gave you that great sheet on the normal physiological changes. It's a good thing. You have fluid and electrolyte balance, and remember the skin and your skeletal differences. And this is a safety, a change in the center of gravity and joint instability because of what? The softening of the ligaments that predispose the pregnant woman to problems with balance. Interventions concerning safety should be part of prenatal education. So what would you say to a patient if she comes in and she's in her third trimester and she, let me see here. She's in her third trimester and she has high heels on.
That she doesn't need to wear those, right?
Right. Because the center of gravity is off. Remember that. Yeah, because you have this big old pregnant uterus, and don't forget her back. She probably says, oh, I'm having some back pains too. That's because she's trying to hold her body up. And then remember the waddling gait? The waddling gait, she's got some joint instability, okay? Because the ligaments are softening up and the pelvis is actually getting a little wider. And so she would have problems that way too. And what complication that we discussed the other day is associated with these center of gravity being off and joint instability, because that leads to what? A fall, right? So
Right.
what complications should she get into if she falls?
Could she have like a threatened abortion or something?
No, she's late in pregnancy. If she falls, what could happen? You can have a placenta abruption, remember?
Oh, yeah.
Yeah. And that's why when a woman, like a pregnant woman falls, she just can't get up and say, oh, I'm okay, or she's in a motor vehicle accident. She says, oh, I'm fine. Don't worry about me. Thank you. No, we send her to the hospital and put her on the monitor to do a non-stress test to make sure that the fetus is okay. This is those complications that we talked about, these are a result of all this, so that's why we always want to know. Okay, so adaptations to pregnancy. So I guess this is, the mom goes through changes and so does the dad. So under mom changing, first we have to accept the pregnancy. Remember, in the first trimester, there's a lot of ambivalence, and so they may not be so happy in the beginning, but then as they accept the pregnancy, it gets better. Okay, the woman has to identify with the mother role. Now, some women say, oh, that's no problem. And other women are just not the nurturing. Not everybody's very nurturing. And so they have to identify with their new role. And then they have to put their own personal life in order, okay? And their relationships. Because not everybody has a great relationship with their own mothers or fathers or husband or boyfriend, and so this all has to be put into order. And then she has to establish a relationship with the fetus, and that's very important. And usually that really comes to play when she has some quickening or when she feels the baby move. I had a patient that looked at me and she felt the baby move for the first time, and she looked at me, she says, oh, I really am pregnant. And I said, oh, yes. Even though she had an ultrasound and she was told she was pregnant, until she felt that baby inside of her, that's when it all started for her. So important in that first movement. And then she has to have, that's part of the emotional attachment. And then after that, when she feels a baby move, it becomes reality. And then she has to prepare for childbirth. Now, not everybody's, goes to classes, though that's the optimal, is to go to childbirth classes just to find out what's going on. But there's really good books now, and there's a lot of YouTube videos out there also. So she has to prepare. So those are changes that every woman has to go through. And then on the daddy side, he has his time, and I would know 3 phases. The announcement phase, where he's identifying with his role. Adjustment phase. He has to put his relationships in order. And then the focus. Now he's preparing for childbirth. So these daddies go through the same type of changes, but they're not so demonstrated like, with the maternal side. Okay. All right. So let's go on here. So, here we go. So here, oh, look at this. We have an emergency, supine hypotension syndrome. Boy, this must be a really important syndrome, don't you think, to see this again? So your signs and symptoms: dizziness, fainting, breathlessness, tachycardia, her heart rate gets really, really fast, nausea, and she starts clammy and damp and cool skin sweating. Those are really bad, okay? So what are you gonna do? Put her on her side. And these will relieve her signs and symptoms, and the vital signs will stabilize. And it don't take very long. It's really fast. Now, we don't usually put them on their backs that long to create this, but this is what happens. So this is why it's called an emergency supine hypotension syndrome. So you have that down packed, everybody?
Yes.
Okay, you should probably see that one again. Okay, all righty. Here we are. We got some skin changes. Okay, so here's your, ooh, poor lady here. You got your linea negra, that dark line. It actually starts with linea alba, which is more of a white line. And then because of hormonal changes, it starts to go dark. Then you got the striae here. Those are your stretch marks. This lady, bless her heart, she got a lot of stretch marks. And it's just the skin. These are skin changes. And these will fade, okay? They don't ever go away, but they will fade. The linea negra will go away, thank goodness, right? Okay. And this lady over here, melasma, or she could have melasma or chloasma is another term. And this is what shows up on the face. Does that look like a mask on her face? It's called a mask. Yeah, it's called a mask of pregnancy. Okay, so these are different hormonal changes that occur with the pregnancy. Yeah, I mean, there's a lot that goes on. All right, now let's get into nutrition, because I know you may have a question about nutrition. Okay, and so we want to increase calories by how many? 300 calories. Here's your fluids. Remember I talked about this already? 8 to 10 glasses of an 8-ounce glass. Okay, so it doesn't mean a little shot glass or anything. It's a big glass. It's 8 ounces, 8 to 10. Now you think, oh, that's not too bad, but it is, because if you go into the bathroom all day as it is, and then you're telling me I have to drink all this fluid, I don't think I'll be too happy about drinking all that fluid. Okay, then folic acid is 4 milligrams or 400 micrograms. And again, prevents neural tube defects such as spina bifida, hydrocephalus. And then protein helps with developing fetus. Okay, usually about 60 grams. And especially in the first trimester, because you have embryonic development and fetal development. Okay, and so we love to get that, but it's hard to get because of the changes in the body related to nausea and vomiting. Now, I'm going to highlight this one, because this one you're going to see again. DHA for fetal growth and development. And where is DHA found? In fish and salmon. Okay. So in that beautiful pink fish, that salmon, so good for you. So if you had a question on the test, which of the following meals offer the greatest amount of DHA? What you think it's orange juice and whole wheat bread?
No,
Okay. How about feta cheese and spinach salad?
no,
Mhm.
How about fruit salad and pork? Ooh.
No.
no,
How about a poached or grilled salmon?
Yes,
Yes.
ma'am.
All right, that beautiful salmon fish. I just love salmon. Okay, it's so good for you. And then weight gain. How much weight gain?
1 to 4
25.
pounds. Oh, well, yeah, sorry, 25 to 35 total, I guess, if that's how
Yeah,
you.
25, 35 pounds. Probably say that again. That's always a good question. All right. So, and then by trimesters, okay, in the first trimester, you're going to gain about 1 to 4 pounds. Okay. And you know, the first trimester is you have a lot of nausea and vomiting, and usually they don't have big appetites. But the second trimester and the third trimester is like 1 pound per week. And then because during this second, third trimester, this baby, is growing, right? There's a lot of rapid fetal growth. And the food safety, always, we're going to wash the fruits and vegetables. We cook all meat and fish, because if we don't cook that meat correctly, what happens? What complication?
And is it bacteria or like infection?
Yeah, it's called toxoplasmosis.
Oh, yeah.
Remember that? Okay.
Yes.
So we got to cook all our meat. We don't eat raw meat. We wash the fruits and vegetables, because you know that your fruits and vegetables have a meat, they have parasites. So we have to make sure that everything is cooked really well. And then the fish gets cooked good too. If you're gonna have salmon, you make sure it gets completely cooked. And then the lunch meat is not the best, so you have to steam your lunch meats. So a lot of times, if you say that to a patient, they go, "Okay, I'll avoid that." Okay. Remember,
I do have a question. Why is that though? Because this pregnancy, I've eaten a lot of like subs, but why is that?
well, because a lot of lunch meats have a lot of stuff in them, and they're very processed, and they have a lot of
Right.
sodium. So you want to basically, they're not really cooked. So you want to stay away from that, or at least steam it a little bit to get all those little bugs out of there.
Okay.
I know. Every time I have it like a sandwich, and I think about that, I go, okay, what is in this processed food? A lot of
Right.
stuff is so processed. But I said I just can't steam this lunch meat. Okay. And then lactation. I always tell my moms, you can get 500 more calories, 500 a day if you breastfeed. They go, really? I go, yes. And to a woman that just had a baby and she's lactating, she's got a good hunger. She's got a good need for food. And so if I tell you kind of 500 more, she goes, okay, that's pretty cool. And also, I'm going to tell you another thing with my patients that I try to get them to breastfeed. I'll say, you want to get in your skinny jeans quicker? They go, yeah. How do I do that? I said, breastfeed. Because breastfeeding releases oxytocin, which makes that involution process go down quicker. Makes the uterus go down much faster, and then she can get her skinny jeans. You use all these little tactics to try to get everybody to breastfeed, okay? Because I know it's very demanding, but it's the best thing for the baby because of the antibodies. Okay. And then we have our adolescents, and remember, no amount of alcohol is safe, because you don't want to put any alcohol in your body, because it goes right through the placenta, right to baby, and baby can get fetal alcohol syndrome. And so that's never good. Okay. So everybody good on nutrition?
Yes.
All right. Okay. What is pica?
When they eat like chalk and ice and stuff like that.
Okay, so if somebody tells you that, you ask about how you doing and how's your nutrition, and they report like, I have this craving, craving for chalk. So they're telling you that. What do you want to know about that?
You want to know how much they eat of it.
Yeah, good deal. Good answer. Okay, remember that answer. Okay, good deal. All right. So here you go. So here's like how we grow. And here we're just starting out, right? Here's your liver and your large intestines. Then there's our little uterus, and there's our bladder, and there's vagina. Okay, so that's pretty neat. That's what we are. Okay, and then here we got our little fetus. Now we're growing. And so here, remember, if we're 20 weeks gestation, we're at the level of the umbilicus. Okay. And so we're growing here, and here's our bone, and you can see how everything kind of gets what? Pushed up, right? You see how the difference in this picture and this picture? Okay, then look at now. Oh yeah, we're in a what, third trimester there, right? And so we got a big baby. No, don't forget, we got about 5,000 mLs in this uterus. So look at our stomachs here. Remember the large intestine was here. Look how nice and it looks here, but look at over here. Everything's squished. And here's your placenta. And here's your umbilical cord. And that's our fetus. And then here's the rectum. And then here's the vagina, right? And this is the cervix, right in there. Okay. All right. So that gives you kind of like a little hint as to how the woman changes as the baby grows. Okay. So that's why here she's got shortness of breath, because everything is being pushed up, and it pushes on her what? Her diaphragm. Okay. And her poor legs and pelvis start to widen. That's why she's got that what? Waddling gait. All right. And here's her back. You see here, see the curvature? They even draw a pretty prominent indentation. That's called lordosis there. And she's like, that's why she got back pain. All right. So the discomforts are real. Okay. And safety. All right. Let's list it up in here. This is important. Travel by airplane if you're less than 36 weeks. Okay. When you get to be 36 weeks, we don't want you in the airplane. What are we worried about someone who's traveling in an airplane?
Blood clots or
DVT.
yes,
Yeah.
thank you.
Yeah, they blood clotted DVT. Yes. So air travel is considered safe, again, up to 36 weeks. Okay. All right. And then car, we have always wear safety belts. And then with pets, we talked about toxoplasmosis, always washing hands after handling animals. So what animal? Cat feces. I always told my patients, always ask, what kind of pet you have pets at home? And they go, yes, okay. And tell me more. Cats, dogs, pigs, whatever. And they say, oh, I got about 3 cats. Well, that's a lot of litter to change. And even with 1 cat, no, you can never touch the cat litter. Okay. And I always tell them, you always are washing your hands after you're handling your animals. Because toxoplasmosis is very bad, deadly to what? To the fetus. All right. And exercise. Walking is our best exercise. We don't, what you want to do is don't raise our core body temperature, because then she gets very uncomfortable. She gets shortness of breath. And so we don't want to do that. We don't put them in a hot tub. You don't want to increase the core body temperature of the woman. Abuse. Yeah, remember, this is all about safety in pregnancy. So you have increased risk of intimate partner violence. We screen all women. And then substance, no smoking, no alcohol, no drugs. Yeah, smoking is very bad for the fetus. It goes right to the fetus. Alcohol again goes right to the fetus and causes fetal alcohol syndrome, and no drugs, because cocaine, heroin, they all pass transplacental. So we don't do that, okay? And pregnant women are they're high risk, right, for a fall. So we want to teach them to raise slowly, okay? Don't get up too quick. Let the body have equilibrium, giving back in equal, especially if she's getting like out of bed. You want to tell her to go over to her side and push off the elbow. Okay. And then we're at risk for blood clots. So no prolonged sitting. You get up and you move around. All right. Okay. So this is pretty important. I would say there's about a couple questions that will come right off that slide. All right. And your danger signs during pregnancy. Chills or fever, what, 100.4 or greater. Painful urination, absolutely, because that leads to preterm labor. Persistent vomiting, you should have nausea and vomiting in the first trimester, goes up to 14 weeks gestation, and then if it gets very severe, persistent, goes into that condition called hyperemesis gravidera. You have changes in frequency or strength of fetal movements. Yeah, that would be a big sign that something's happening inside. A lot of times when they say my baby's not moving like it should, nurse, you need to call the hospital, call the clinic, wherever you get your fetal prenatal care. That needs to be taken care of very quickly. Signs of preterm labor, if you're having uterine contractions, cramps, constant or irregular low back pain, and pelvic pressure. Now, some of this, like irregular low back pain, could be maybe she's got some painful urination going on. So I'll do a urinalysis, take care of maybe the UTI that started, the cystitis, and all of a sudden this will get better. So these are things that we teach and say, if these things are heads up, then you need to come to the hospital. And AWA is my organization for obstetrics and gynecology. And we have like a refrigerator magnet we give to the patients, and it has the danger signs on them. Okay. All right, moving right along. We have miscarriages, or we call them spontaneous abortions, and here's your different types. Now, you know about the threatened abortion because it has mild cramping, spotting, or light bleeding. Now that was on your quiz, right? And yes, it was.
Yeah.
Okay. Yeah. Okay. So you want to take note to that. And so again, threatened is mild cramping, spotting, or light bleeding. Now, when it threatens, it means that something's happening, right? And so we may have a little bit of vaginal bleeding, but the cervix is closed and she's having some mild cramping. So what we can do is she goes to bed rest, nothing in the vagina, and let's get through this. And a lot of times we can stop the cramping and the bleeding will stop. Okay, that's a threaten. All right, it's scary. It's absolutely scary because there's a possibility that it can get worse. So that's why bed rest is important. Inevitable abortion or miscarriage, it has a lot more bleeding. It has cramping, and see how the cervix now, the cervix is actually dilated. See, and then all this blood starts to come out of the membranes. And so I can't do anything to help this. You know, it's just gonna pass on its own. And it's sad because we just can't do anything about it. And then you have incomplete abortion, where you have bleeding, cramping, and you have the passage of tissue. And then what happens with this is that she doesn't pass everything. So there's a lot of tissue still up in the uterus. So it's called incomplete. So on these, you would have to do a D&C or a dilatation and curettage. All right. And on this one, if she doesn't get all the products of conception out, then we would have to do a dilatation and curettage, because we can't leave anything up in the uterus. All right, so those are your different types of spontaneous abortions. If someone does have a miscarriage, we let them, they grieve, just like if they, had a term baby, because they need to grieve. These are babies, and they lost their baby. Okay, and so we recognize that has come a long way in the grieving process for these women. Now we're going to go into late pregnancy bleeding. All right, and so this one was a product of what? Early pregnancy bleeding. Okay, and now we go into late pregnancy bleeding, because this is where now you can see you have a large, you have your baby inside. This one is placenta previa, and placenta previa means that the placenta is laying low. Okay, so here's your placenta, and it's over the cervical os. You can have marginal, where it gets like 2.5 centimeters to the os, and then complete is completely covering the os. All right, and what happens is that the placenta, it just doesn't implant properly, and it now is down here. And a lot of times these babies will not be what we call vertex presentation. They'll be in a breech, or even transverse, laying across, is because the placenta is taking up all the room down in the lower segment of the uterus. Okay, and the main thing I want you to remember is painless bright red bleeding. And painless is because you're not having any contractions per se, but you do have bright red bleeding, because again, the placenta is down here, the cervix right here opens up a little bit, and you get some bleeding. Okay, so she's not contracting or anything, but she is having bleeding. So that's why it's called bright red bleeding. Okay, and you're not going to deliver her vaginally. There's no way that you can deliver a baby coming through with the placenta first. Okay, so you always want to call the physician if she comes in and she's got a diagnosis of placenta previa and she's bleeding, and you want to call him to let him know, because he needs to come and evaluate her quickly, because then we have to what? We have to go back for a C-section. The risk for this, there's a risk factor, and she's more at risk for hemorrhage and shock. The hemorrhage, yes, because a lot of times, even after we take the baby out, she's at risk for hemorrhage, is because the placenta was so low lying that it weakened this part of the uterus, so it doesn't contract properly. So she gets a condition called uterine atony, A-T-O-N-Y, and that's a uterus without tone. So again, and patient can go into shock because she lost a lot of blood. Okay, remember the first thing you're going to see when a patient goes into shock is tachycardia, and then you get tachypnea, and then you got hypotension, blood pressure goes down. Now that's placenta previa. On the other hand, you have placenta abruptia. So here you can see where the placenta is, right? Okay, and you see this little area, you can see where placenta actually pulled away from the lining of the uterus called the endometrium. It pulled away. And so now you have blood, and you can see, you can trace this blood, how it comes down, this way. So this is never good. Okay, so it could be that she had a trauma or some vasoconstriction. A lot of times preeclampsia puts them at a risk for placenta abruption. And so you can see how it pulls away, got the hemorrhage. And when the blood comes down, because it's got a longer way to go, all right, you follow me, everybody? Got a longer way to go. The blood, when it comes down, is more dark, is dark red bleeding, okay? And this here is painful, because what happens is you have this accumulation of blood in the uterus, and it makes that uterus like a board, it's hard, and it's very rigid. And when you put a patient down to evaluate her, you can just see her abdomen. This whole uterus makes her abdomen look so different. And she's complaining of pain. Okay, now she's at risk for hemorrhage, the same thing, and for shock. Okay, so again, any questions on placenta abruption and placenta previa?
Yeah, so my understanding of it is that placenta previa is an issue kind of with the location of the placenta,
Yes.
and then placenta abruption is the attachment of the placenta, right?
Yeah, the loss of attachment. It pulls away from the lining of the uterus.
Okay. Okay.
Yeah, and and this is why you can see why it would be painful, because this thing, anything that abrupts off another wall, or substance abrupts off something, you're going to have pain. You're going to have fluid in here too, and that's why this fluid changes. You're going to have all this bleeding inside the abdomen, and this causes the actual uterus to change and causes her abdomen to be rigid, very rigid. And then something that's like this would cause it to be very painful. And then it's dark red bleeding because it starts like up here where it pulled off, and then it has a longer way to come down and to be expelled from the body. And so by the time it gets down here, is darker. Any blood changes as it travels down, so it could be darker red. Where on this placenta previa is bright red, because the placenta is laying low, and so it sloughs off quicker. Does that make sense?
Yes.
Does that help? Does that help? Okay. All right. So can you see the differences in these different incidences of bleeding in late pregnancy? Okay. All right. Now, someone that is trying to get, she was trying to get pregnant, and she got pregnant, and then all of a sudden she has all this. It's very dramatic, these things. Placenta previa, she's got to be on bed rest, nothing in the vagina. And she's always, it's very stressful time, because they're always thinking, when am I going to bleed, and then they know C-section is going to be. On the placenta abruptio, she might have got into a motor vehicle accident, or she might have got a hit and caused this, or preeclampsia, it caused this placenta to actually break away due to the with preeclampsia. There's so much vasoconstriction going on, it makes it break away. Okay. It's a dramatic time for both these mommies. All right. And again, this is just another picture of placenta abruption, and you can see where it shows like a board-like structure. See how different it looks, the abdomen. And so that's what you want to know. And again, I talked about already, the dark red bleeding. Okay. Okay, hang in there, guys. We're almost finished. Preterm labor. And what is preterm labor? Well, it's labor after 20 weeks, because 20 weeks is viability, and before 37 weeks, because 37 weeks turns into term. So, do we want anyone to go into preterm labor? No. Okay. Preterm labor, we try to keep the baby in the natural incubator as long as possible. All right. So remember, here's your definition: labor after 20 weeks. So 20 weeks again is viability, and before 37 weeks. Now, we can give mom a drug called betamethasone. Okay, and it's right here, betamethasone. And what that is a steroid injection. And that's given to mom in 2 doses, 12 milligrams and IM, and it's given 24 hours interval. Okay, so I give it today, say at 5 p.m. I'm gonna give it again to mom tomorrow at 5 p.m. Okay, it's 24 hours. And what this does, it's a steroid. So, you know about steroids, it increases increases things. So what happens is that at about 25 weeks gestation, this surfactant has been started to develop at 25 weeks. So you need surfactant to allow the alveoli to remain open for adequate lung oxygenation. So, because the biggest job this baby has at birth is to breathe. Okay, so if I have a woman who is 26 weeks gestation, okay, my biggest fear for her and for the baby is for that baby to breathe, because I know surfactant has just started to develop in this fetus. So I would get an order from the doctor to give her this betamethasone and to give help to this fat baby by increasing the amount of surfactant. So that's what this drug does, is given to mature his fetal lungs. Now, it does work very well. Babies come out. If they're 27, 28 weekers, they're going to have a little slower time breathing, honestly, because once the cord is cut, but then they'll go to NICU, the NICU, and they'll probably intubate that fetus, the baby, and then they can give the baby they can give him more surfactant, like through a liquid, and they'll put it right down the ET tube, and that really helps too. So all of this, this betamethasone helps to mature the fetal lungs by increasing the production of surfactant. It's like, this is like a stimulant to the surfactant. It says, okay, hurry up, get going, start producing more, okay? And then the baby has a better chance when it's born to breathe. Okay, now we get a classification of drugs that are called tocolytic. And that could be like terbutaline, that's magnesium sulfate. Those are the two drugs I use a lot to stop labor. And what happens is they able to relax the uterus. Okay. And, again, we want to stop preterm labor if we can. Now, the thing is, if they are less than 2 centimeters, we have a better chance at stopping labor. Once they get above 2 centimeters and the effacement of the cervix is completely effaced, that's hard to stop, okay? And so we realize that we're not going to be able to stop them, then we'll get an order for the betamethasone and get those fetal lungs to be mature. Does everybody understand this slide?
I have a question about the tocolytic drugs. So do you use them like in conjunction with each other, like all of them together, or
No.
like you just
One.
choose one?
Yeah, it's all according to your physician who you're working with in your hospital and their protocol. The drug of choice we usually use is magnesium sulfate, because that's a central nervous system depressant. Just like it works, with our preeclamptic patients to prevent seizures. It's a central nervous system relaxant, so it relaxes the uterus. Okay.
Okay.
So it works like a charm. You just have to be careful with these drugs because they do have some side effects. Magnesium, you have to worry about magnesium sulfate toxicity. The terbutaline, we give sub-Q, and that can increase her heart rate. So you have to be very, very careful with these drugs. They do have their side effects. But no, we use well, you don't use them together, use one, okay? But it's just according to your physician. And usually it's the magnesium sulfate that can stop those contractions. We use that to in premature labor. We always want to stop it as much as we can. Okay, any other questions about the slide about preterm labor?
No.
Okay, good. All right, so we're going to move right along here. All right, that was that one. Okay, so remember the other day, last Tuesday, we talked about chapter 5 and the complications of pregnancy, and we talked about preeclampsia. So we want we want the blood pressure to stay normal in pregnancy, right? And we are very concerned if it starts to get to 140/90 after 20 weeks, because we're thinking of preeclampsia. Okay, that's when, and the culprit of preeclampsia is the placenta. That's why this is here, 20 weeks, because that's when it shows up as ugly face, I say. It's like, okay, you're causing her problems. And what happens in preeclampsia? You have protein, you're spilling protein, so you protein the urine. When you spill things in your urine, it's because you've gone over the threshold. And so now it's going to come out of your body that way. So it gets into protein, your body secretes it. The edema starts in the hands and the face. You start to see that. Again, because the excess amount of spillage of the protein, you can get kidney involvement. And then during preeclampsia, she can have elevated liver enzymes. So the liver then gets involved.
I have a question. On the case study that we did, it was asking us about, I guess what we did in SIM, like the whole preeclampsia thing. And it was asking us on there, I guess, to indicate or like to pick out what is abnormal symptoms, I guess. And one of them was +4 plus DTR.
Yes, that's hyperreflexia. Your DTR is your deep tendon reflexes.
Okay.
Deep tendon. So what we do is we check the reflexes. The easiest place to do it is in the knees. And you always have to be careful when you're doing reflexes on a patient. Don't ever stand in front of them because you can get kicked. So if you've got +4, remember reflexes go from +1 to +4. Okay, so we like to see it +1, +2 is okay. When you get to be +4, you get to be called hyperreflexia. Now she's 4+. We got a severe preeclamptic.
Okay, I just didn't know what was like the normal limit, I guess, for the DTR. Okay.
You got it?
Yeah.
Oh, you're welcome. Okay, so again, preeclampsia shows up as protein, edema, kidney, or liver. All right. Now, it does affect the whole body, does it not? So now, when the difference between the term gestational hypertension, that means hypertension acquired in pregnancy, there is no system symptoms. Okay, that means the kidneys are not involved, the liver is not involved. You don't have systemic problems. You just have an elevated blood pressure. Okay, so you see the difference where with preeclampsia, it affects your whole body. All your systems, your kidneys, your liver, your blood volume, your edema. These are things that get affected with preeclampsia. You got the difference between preeclampsia and gestational hypertension? Okay, now what happens is you can get into what we call a danger zone. All right, and so now we're getting danger headaches. Okay, these are headaches that I tell you, my patients came in and they would hold their head like from the front to their back, their head, and they're going, oh, I got this headache. And I took Tylenol, nurse, and I just can't take this anymore. That's not good, right? Vision changes. She sees spots before her eyes. I think I told you the other day, my patient in labor, she's like, what kind of hospital is this? You got bugs in here. I went, oh, well, we don't have bugs, but I can, let me check your blood pressure again. Okay. The vision changes. She can have double vision, blur vision. She has decreased urine output. Now, can you see how things are getting worse with this patient? And now she has that upper GI pain. Remember I told you it's right on a woman, it's right underneath that right breast. That's a GI, that's upper GI pain. It's very significant. That's called epigastric pain. That's EPIGASTRIC, epigastric pain. When your patient tells you that she has that kind of pain, her condition has now gone into a real danger zone. Okay, that's what we call a worsening symptom. And then she has significant edema of the face and hands. Okay, now I'm going to tell you a little tidbit. When your patient complains of epigastric pain, the next symptom to happen to that patient is a seizure. That's why it's very, very significant when she gets to that point, because she's real close, but the next thing would be a seizure. And then she goes into eclampsia. Okay, so what do we want to do? Well, I don't want my patient to have a seizure. So I'm going to give her magnesium sulfate to reduce the seizure risk. Okay, so that's why when she comes into the unit, we jump on her. We're going to give her 4 grams loading dose of magnesium sulfate, which is a good amount of medication to give very quickly. But we want to get that in because I don't want to involve the brain, because then you get really bad when you involve the brain. Okay, any questions about this? Are you
No.
following me okay?
Yes, I'm fine.
Okay, good. I just want to make sure. And because I tell you, there is a question on this. Okay, let's go on. And these are, we talked about this on chapter 5, the pregestational and gestational diabetes. Now, it's pregestational, it means it's happening what? Before she gets pregnant. So it's diabetes before becoming pregnant. And these kind of patients are more prone to have a baby born with a congenital anomaly. Because in the very beginning of pregnancy, when the embryonic stages are going on, the embryo is just developing, there is a high glucose level. And that's what causes this congenital abnormalities. So we want to have good blood sugar control because it decreases the risk. It kind of makes sense. So we have to be careful with our type 1 diabetics or our obese patients that get pregnant, because they could have a chance of having a baby born with congenital anomalies because of the risk involved with the hyperglycemia. So remember, insulin needs do increase in pregnancy. And so we do a 3-hour glucose tolerance test around the weeks of 24 to 28 weeks gestation. And we test in the urine too. Every time she comes in for each of her visits, we test her urine. And we're going to test that urine to see if she's starting to spill any glucose out. Because the sooner you get her on a diet, proper diet, maybe she's not eating correctly, the better chances are for the fetus. Now, we're going to have her walking. We're going to have it on our diet chart, and then we have this nice little meter, a glucometer, and we teach her how to test her blood sugar. Okay, and then she comes in, and she'll be put on a monitor, and we're going to do a non-stress test on her. What we're doing is on the baby, and we're just checking for fetal well-being. Okay, because a lot of things, can go wrong now because of too much sugar in the body. Does that make sense? Are you guys okay with that? Hello?
Yeah,
Okay.
we're here.
Yes.
Okay. I just making sure you're still with me.
No, we're here.
Okay. Now, remember I talked about that NST, fetal well-being? Well, here is a little slide that shows you everything about it. And daily kick counts. Now, I would know that 10 movements in 2 hours, at least 10 movements in 2 hours. They're typically felt between 18 to 20 weeks and evaluated with NST if no fetal movement. So remember that lady on the monitor, right? Well, if she says, I had patients walk in the hospital and say, I haven't felt the baby move. I get them right on that monitor very quickly because I want to I want to make sure I hear a heartbeat, and then I want to make sure I do this non-stress test where I evaluate if the baby's okay. Now, an NST, I think we go over this in the next chapter, so I won't go too far into this, but it's a non-invasive test. And so you just put external monitor on, and what we're looking for acceleration of the baby's heartbeat with fetal movement. Okay, so then we know the baby's okay. Now, another test for fetal well-being is ultrasound. Again, that's a non-invasive test, and it can determine fetal age and review of all the systems, and it can show anomalies and assess for fetal growth. And the IUGR stands for intrauterine growth restricted. So ultrasounds usually are good. Everybody likes ultrasounds. They can see the baby. I already went over non-stress tests. And then you have this contraction stress test. Well, contraction stress test is done where we actually give the patient a little bit of Pitocin, and that's a synthetic version of oxytocin. And what we're going to do is we're going to give the patient some contractions. Now, they're not what we call labor contractions, but they're contractions enough. And because we don't want to put her into labor. And what we're doing is we're seeing how this baby tolerates these small contractions. And if the baby's heart rate goes down during a contraction, he's not going to tolerate labor. So that would not be a good test. So that's called a contraction stress test. Okay. And we don't do it that often, I'm going to be honest with you, but it is a good way to evaluate if this baby can tolerate labor. Because some babies can't even tolerate labor. Once mom starts to have contractions, and we'll learn this in the next chapter, is babies, sometimes his heart rate will go down. Okay. And then you got your, then your next test is your biophysical profile test. Now that biophysical profile test is a group of 5 fetal assessments. And what we're looking at, guys, we're looking at fetal heart rate. We're going to look at fetal breathing. We're looking at fetal movements. We're looking at fetal tone of the baby, like, closure of his hands, that's tone, and the volume of amniotic fluid. And a lot of times when they have a fail, this non-stress test here, it's not reactive, then the next step is to look at the baby more closely, and we'll do a biophysical profile. Because the biophysical profile, each category gets points, and mom doesn't have enough points, then baby is in trouble, and then we do a cesarean. We get the baby out. So that's called a biophysical profile. Okay. Now here's your group beta strep we talked about before, and we talked about just the other day. Again, it causes a perinatal infection with high mortality rate. These babies, as I said, they go into respiratory distress. It's found in the woman's rectum, vagina, cervix, throat, or skin. And we do a culture in the arm, cervix, vagina, and then they'll do a swab in the rectum. The risk of exposure to the infant is great if the labor is long, or she has a premature rupture of membranes. Because then that she's brought in, she's got premature rupture of membranes, we're going to bring her in and give her antibiotics during labor. Okay. If she has a dysfunctional labor, then infant is at greater risk for during that. And again, we take care of the problem by giving antibiotics during labor. Now, the GBS is very significant because it does cause maternal postpartum infections too. So that's why, again, we want to go ahead and give mom an antibiotic. And we've had years ago, back in the, the late 70s, early 80s, we had infants that actually were dying because they came through a vagina that had group A strep. And we did not give antibiotics during that time because it wasn't known. It became more prevalent in the 90s. And I share with you that I did my own thesis on this and got some changes. So it does, it's very significant that this did change. And then we culture every woman now, because years ago, they didn't culture every woman. Okay, we're almost finished. Got a couple more, promise you, and then we're done. But anyway, we got another thing we're going to talk about is what? Incompatibility. Okay, so what happens? Remember this. You have an Rh negative mom. Okay, we don't know what baby is. So you have an Rh positive. We're assuming that we have an Rh positive baby, right? So we have to treat it that way. What we're going to do is we're going to give mom Rogaine. And I know Hesse has questions on this. And what you want to remember, they don't use the term Rogaine. They call it RHD immune globulin. And now you probably see that in your reading. So again, what are you going to give her? RHD immune globulin or Rogaine? And this incompatibility between mom and baby is because mom has Rh negative, right? And she has these antibodies. And they're just like little pack women. And here's baby. And what happens is we don't really want the mixture of blood, but it can happen. So when that happens, mom's antibodies, get to eat up baby's erythrocytes. Now, erythrocytes are red blood cells. So these antibodies are eating up all these red blood cells. Okay. And so what happens to baby? Baby gets anemic. Okay. So we want to prevent that. And if we give mom Rogaine about 28 weeks gestation, we can prevent that for this pregnancy. Then after she delivers, guys, we give her another Rogaine injection. And that's around 72 hours after delivery. And that's because we're going to protect the next pregnancy. So in the very beginning, when we talked about that prenatal visit, the first time, we're going to do all our blood work. And that's why we test her blood to get the Rh factor, because we want to know what we're dealing with. Do we have an Rh negative mom? And if so, then we need to put an alert in our computer system that when she gets close to 28 weeks, when she comes in for that prenatal visit, we're going to give her blood request, and she's going to go over and get her blood drawn and get her Rogaine. Okay. All right. Everything good? All right. And we always watch the baby during the pregnancy. So we'll do our fetal assessment test, such as the non-stress test. And then babies can be very severely anemic. And when they get very bad, they can have what we call an intrauterine transfusion. Now, those are really severely anemic babies, but it can happen. Okay, so that's why we give Rogaine. All right, everybody good on Rogaine? All right, are you still there, everybody?
Yeah.
Yeah,
Okay,
we're here.
Okay, good. Okay, the next one is toxoplasmosis, and we talked about that. That's that parasite. I think we talked about it quite a bit. Is contact with cat feces, raw meat, transmitted through the placenta. Okay, what happens to the baby? Baby has low birth weight, has enlarged liver and spleen. Jaundice is pathological jaundice, which is the more severe type of jaundice. Anemia, inflammation of the eye structures, and neurological damage. Yes, so someone that comes in and that is prone with animals or cats or eats raw meat, this is what I go over with them very clearly, because people go, oh, really? And they go, no, really. So it is, we don't want them to come down with toxoplasmosis. And then we have the human immune deficiency virus, and that's a virus that causes AIDS. And what it does, it cripples the immune system. There's no known immunization or curative treatment. And it is acquired in 3 ways. You have sexual contact. You can have mucous membranes exposed to infected body fluids, and perineal exposure. Infants, yes, infants do get affected. It crosses the placenta. They get contact with infected maternal secretions at birth, and it goes through the breast milk. So a lot of times especially on newborn tests, they'll have about breastfeeding. They cannot breastfeed. Okay. Let's see if I have any questions on HIV. All right. Let's see here. Let me see if I have any. Not that I'm coming across. I have looking at my review sheets here. All right. Okay, but just know you cannot breastfeed with an HIV. All right. So now, interventions for the grieving process. Okay, remember we talked about the miscarriage, abortions, ectopic pregnancy we talked about in chapter 5. Those are all, we have stillborn, we have a loss of pregnancy or a baby, right? Okay, so we have these interventions, and you must follow these. So you allow the parents to remain together in privacy. Yes. They're going to grieve. So I've had parents where they got very emotional and crying, caring, really just grieving. You have to. They have to grieve. They always say, if you love deeply, you grieve deeply. They develop a plan of care to provide support to the family. You offer a memento. Remember we talked about that the other day. Footprints, a lock of hair, handprints. Ask the parents about what they like in the memento box. A picture. Okay. Offer parents an opportunity to hold the infant. Now you ask them, and usually what I'll do is during if it's an induction of labor for stillborn, what I have to do is during that time, I'll ask the parents if they like to hold the baby or not, and then they let me know. Because some don't want it, not at all, and just take the baby out of the room. Okay. And then some ask me later, can I see my baby now? And the baby's in the morgue, and I say, sure. Give me a few minutes. I'll go down to the morgue and get the baby. You have to call security, and they'll go down with you and get the baby. And you prepare the parents for the appearance of the infant. Yeah, because some babies, if they've been expired in the uterus for a while, their head will be sunken in because remember there's decrease of amniotic fluid now. Provide parents with educational materials and referrals to support group. And they want to and also discuss with them their religious and cultural rituals. Okay. All right. So again, that's the grieving parent. All right. So remember, guys, you have 5 math calculations, and take your time with them, read it, and what is it asking you? And don't label your answers in math. Just, if it's 1.8, just put, 1.8 or 2.5, whatever. Don't label it. And you should be okay because you've done great on the dosage calculation worksheet that we gave you. So you should be okay. And you should be okay, and also know how to do a total intake, but you all did good on that, so I think you'll be fine. And there's 5 math, and then there's 45 questions covering chapter 2 to 5. And this was a really good, really good review on that. And so do you have any questions? Any questions?
No.
No.
How do you feel about it? Are you feeling more prepared?
Yeah.
Yes, and then of course I'm gonna review all the material that you just gave us as well. You know.
Oh, yes, yeah, good, 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 good. Okay, so you should do very well. I did give out some test taking strategies, under one of the announcements. So, all right, you might want to look for that. Remember something, okay? Remember just to ask yourself, what's the question asking me? I always tell my students, slow down, read the question and ask yourself, what's that question asking me? All right. And then you go and you can see the different choices. Just again, you got time, you can do it. And just take your time reading the questions. Okay. All right.
Okay.
This is my conclusion. Have a great day and you will be well prepared for Tuesday.
Thank
Okay.
you.
You're welcome.